Okay, so today I'm going to talk to you about the psychotherapy for transgender declaring young people and adolescents, a hugely contested and a very ignorant debate that has been carrying on, particularly in the context of these ridiculous conversion therapy ban legislation laws that have been enacted throughout Australia. The developmental processes from infant temperament to adult personality are very complex, and nowhere in the gender-affirming literature have I ever seen a decent analysis of the process whereby a child, an infant, goes from having their innate characteristics such as their infant temperament, cognitive capacity, and the beginning of their relationship and life history as the raw ingredients to their adult personality, explicated in any intelligent way whatsoever. And yet the ignorant lobby of gender-affirming care assert that 6, 8, 10-year-olds know who they are, even if they are opposite to their biological sex, and can give informed consent. And in fact, the gender-affirming care should be child-led and adults should not stand in their way. And yet children develop maturity in their adult personality through an iterative process of the development of some of the features which I don't have time to go through in this presentation, but multiple processes iteratively developed and which continue to what we understand now to be the mid-20s. And, you know, I would really challenge the gender-affirming care clinicians in all the major children's hospitals to perhaps come to my developmental psychology lectures and learn a little bit about child development. So moving on to the available models of care for gender dysphoric young people. Well, basically there are 3 models. And we've all heard ad nauseum about the gender-affirming care model or the gender-affirming therapy model, grossly misnamed and misleading. And the basic tenets of these kinds of models is that affirmation and confirmation of the young person's wishes without ongoing exploration of any of their life or family issues should be undertaken once they present to the gender clinic. And this is what is laughingly known as the informed consent model. They advocate in favour of early medical and surgical interventions because they claim that the final result is better. In other words, they pass better if they are blocked and cross-sex hormoned at earlier ages. And Alison's just taken through the reason why early blocking and cross-sex hormones can have devastating effects on adult function. And finally, it is assumed that experts can predict persisters and desisters with certainty, and so they have this omnipotence that all of the children that they eventually transition will not, in fact, desist or detransition. And they perpetrate yet another myth that the detransition rate is only 1%, which is just laughably inaccurate. The second model is what is called the gender reparative model, and this model was implemented in the 1950s, 60s and 70s to convince gay young people to adopt a heterosexual sexual orientation. So it was a treatment that was an active attempt to alter the young person's gender identity and or sexual orientation. The therapeutic encounter was seen as a cure for homosexuality, and it is based on normative ideas about gender, and that is that we all need to be cis-het as the jingoistic language goes. That means cisgender and heterosexual. The third model which I practice and which I'm going to talk mainly about today is called the gender exploratory model. I don't actually like that terminology because what I actually do is a very well-established therapy called psychodynamic psychotherapy and adjunctive family therapy for children who are presenting with gender dysphoria. This model is open-ended and it does not have a pre-defined outcome, and one of the main principles is to assist the young person and their family to make meaning of their presentation and of their symptoms. Now, both the gender reparative model and the gender exploratory model are treated as if they were equal because they're not the gender affirming model, and they're both subject to conversion therapy ban legislation. And for these views, I'm now being prosecuted by the ACT Human Rights Commission for practicing conversion therapy and vilification. What are the principles of that third model, which I'll call gender exploratory therapy, just for clarity in today's presentation? Well, firstly, it's open to a range of outcomes. It understands that gender dysphoria emerges in a social context. It is not innate and the child doesn't just know at 2 to 3 years of age. It is developmentally informed. It considers and addresses comorbid conditions. It acknowledges the complex interplay of sexual development and gender identity. It is a process that occurs over an extended time with regular therapeutic contact. It maintains an evidence-based approach to suicidality and all other factors relating to development, and it promotes true informed consent once the young person and their family has understood the meaning of the presentation. So the principles of treatment are that psychological, psychiatric and psychosocial comorbidities predate the onset of gender dysphoria. Young people with gender dysphoria almost always have psychological, psychiatric and psychosocial morbidities. Social transition and puberty blockade are not neutral interventions. Puberty blockade interrupts the progression of normal development, which may not be reversible after prolonged use. Both social transition and puberty blockers facilitate progression to cross-sex hormones. Puberty blockade is also a health risk, as we heard from John Whitehall earlier today, that prevents children from resolving their gender confusion and precipitates their boarding of the trans train. Cross-sex hormones have no long-term positive health benefits and do not resolve identity confusion or reduce suicide. Medical and surgical interventions carry high risk for lifelong mental and physical health problems, and a child cannot give informed consent to life-altering interventions. Gender dysphoric young people have bodily perceptual disturbances, and it belongs in a similar category to anorexia nervosa, body integrity identity disorder, body dysmorphic disorder, and muscle dysmorphia. Van Zyl described all of these conditions as a complex of affective perceptual disturbances focused on the body, but accompanied by manifestly severe emotional and psychological distress. Mood disorders are almost ubiquitously present in most of these affective perceptual disorders, and it is not a kind of emotional distress that can be acknowledged or articulated, and therefore it's introduced into the body, and the body becomes the focus of the dissatisfaction. There are several personality characteristics in those presenting with body image disorders, including being temperamentally resistant to change, a propensity to ignore or deny emotional discomfort, and impaired capacity for mentalisation on a background of having experienced unresolved developmental challenges or trauma. In opposition to the conceptualisation of gender dysphoria as part of a complex of disorders of affective perceptual disturbances focused on the body, DSM-5 and DSM-5-TR gives a separate chapter to gender dysphoria, failing to see the conceptual and psychodynamic similarities between gender dysphoria and the other body-focused clinical disorders. It is noteworthy that society and the professions do not collude with the young person in these other body image disorders. All but gender dysphoria are perceived as psychological disorders requiring psychotherapy as the first line of treatment. Once the projection of distress and a seeming solution in bodily correction have been identified, the distress appears to resolve, erroneously confirming the focus of treatment on the body as correct. It is extremely difficult to assist a young person to retreat from such a position, particularly when the medical profession colludes with the reality-defying goals of changing sex. Most children will grow comfortably into their sex-based designated gender if their developmental trajectory is not derailed by early medicalisation. Currently, there is no clear reason for those who do not. We do not yet have sufficient evidence to assign causal roles to biology, cognition, or socialisation, including familial dynamics, trauma, or enabling social factors, or a combination of all of these factors. A complex interplay determines the end point of a declaration from the young person that they are transgender or non-binary. We do not know that attachment trauma or disruption, maladaptive coping strategies, peer relationship difficulties, and internalised homophobia and misogyny all require careful exploration. While a transgender declaration often brings the family into therapy, it ceases to be the focus after the individual structural and systemic factors within the family have been illuminated, analysed, understood, and resolved. I would like to give you a flavour of the complexity entailed in working clinically with young people with gender identity issues. I will begin with enumerating the dimensions that must be assessed and addressed in therapy. I will then illustrate some of these dimensions with case studies from my own practice that demonstrate the varied presentations and personalised requirements for ethical care of these young people and their families. So we must begin with a careful intake assessment. I always meet with the parents first before I meet with the young person. That is for all young people who are continuing at that time to reside in the family home, in their nuclear family. Issues of interest are the degree of family conflict, dysfunction, marital and sibling dynamics. I then do a psychological evaluation, assessing for the presence of attention deficit hyperactivity disorder, autism spectrum disorders, the presence of self-harm, suicidality, suicide attempts, anxiety, depression, incipient borderline personality disorder, and in rare cases, a psychotic process, which usually presents itself in mid to late adolescence. One also needs to explore the history of body dysmorphia and eating disorders. What is the child's school life experiences like? What is their attitude towards school? What is their school achievement like? Have they experienced peer rejection, bullying, truanting, post-school aspirations? What is the cognitive process of these children like? Do they evince cognitive immaturity, concrete thinking, cognitive rigidity, or cognitive distortions? A lack of understanding or a misunderstanding of gender ideology and capacity to critically review it, given that it is nonsensical and illogical and scientifically unfound. Understanding the gravity and irreversibility of medical and surgical transition. What gender-affirming treatment entails and the consequences of treatment, for example, infertility, sexual dysfunction, complications of cross-sex hormones and surgery, and lifelong patienthood. Have they had any sexual experience? History of sexual relationships, sexual abuse experiences, sexual knowledge, and sexual anxiety? Is there an emerging awareness of ego-dystonic sexual orientation which may lead to internalised homophobia or misogyny? What about the influence of social contagion? The influence of the social milieu, such as schools, the gender clinics, the internet, influencers, online transgender communities, and overly enthusiastic affirming parents. What do they perceive about the meaning of gender roles, and do they conflate gender roles with gender identity or sexual orientation? And what is the systemic function of the young people presenting with rapid onset gender dysphoria? It could represent a defiance of parents, the need to find an in-group, the yearning to be seen and heard and recognised, a denial of the development of their sexed bodies, a fear of adulthood, and a fear of sexual relationships. Of great importance is the relationship between a desire to transition and the presence of self-harm and suicidality. The vulnerable, traumatised part of the self is hated, so it is subsumed into the omnipotent self, which is the part that suppresses doubts and anxiety and presses for transition. If the traumatised self pushes for recognition of psychic pain, the young person may resort to self-harm and suicidal ideation, which is a form of acting out of their self-hatred against their bodies. Affirming clinicians collude with the patient's own attacks on the traumatised self by traumatising their bodies with cross-sex hormones and mutilating surgery. hope that transition will restore the young person to an ideal state, medics become the omnipotent creators of this ideal state. When this fails, the patient sinks into further self-hatred, which is enacted through self-harming, suicidal states, and for some, a completed suicide. We know that the suicide trope of the transgender lobby has been thoroughly debunked in a number of very robust studies, the last two of which were conducted in Belgium in 2025 and the Finnish study in 2024. And preceding these two studies was the important study by Michael Biggs in the UK that found that of 15,000 young transgender declaring people, there were only 4 suicides. In the Belgian and Finnish studies, they confirmed that gender dysphoria did not predict all-cause mortality or suicide mortality after psychiatric morbidity had been controlled. So in fact, the suicide rate both before and after transition was predicted by psychiatric illness rather than the fact of gender dysphoria. But one of the most important findings is that suicides were 3 times higher in the gender dysphoric group as opposed to controls after transition, not before. Now, I won't have time to go through all of the different case presentations, but I will just choose a couple to give you a flavour of the complexity of what we're dealing with in a proper psychotherapeutic intervention, as opposed to the 1 or 2 sessions that children are required to undertake at gender clinics. So the goal of therapy is to understand the symbolic or hidden meaning in the symptom, which is the gender dysphoria. And the true target of treatment is to uncover the symbolic meaning of the literal. So the literal is the gender dysphoria. I'm born in the wrong body. I hate my body. I can't look at myself in the shower. I shower in the dark, and the trope goes on. So one example of the hidden meaning for one child aged 8 was unresolved grief. James, 8, expressed a wish to become a girl after the death of his beloved grandmother, who was his primary attachment figure. He had no words to express his grief, so he became, symbolically, his grandmother. When he found the words to express his grief, he spontaneously relinquished his concrete identification with his grandmother. Sibling rivalry is a very significant part of the gender dysphoria complex, and I find it in between 60 and 70% of my case load. And this very, very often occurs in a family constellation where there is a brother and a sister, 2 children, 1 male, 1 female. And the transgender declaring female believes that the father loves only the brother, and she then yearns for the father's love by thinking that she will obtain it by becoming male. A history of some form of sexual abuse or sexual trauma and the experience of a lack of safety as a female is also a very prevalent presentation. So family constellation is an extremely important aspect of understanding gender dysphoria, and we do have to understand that identity is not hardwired as claimed by gender ideology. It actually develops in a social world where the young person experiences attachments, traumas, abuse, or misperceives the meaning of experiences because of cognitive immaturity or concrete thinking. We need to explore identifications, that is, I want to be like someone, and disidentifications. I do not want to be like someone in my family constellation. So other presentations are particularly difficult to treat are those children with severe cognitive rigidity, and this includes children on the autism spectrum. They make cognitive errors, they're very rigid in their thinking, they cannot attention shift, and they find it very difficult to introduce new information when it's presented to them. Another very common presentation is an escape from homosexuality and gay relationships. Some young people will tell me that if they transition, if they're same-sex attracted and they transition, then their relationship will be heterosexual and all will be well. Another presentation is a vicarious fear of being a woman. And I've had a couple of cases where the mother of a transgender declaring female adolescent has told her child, perhaps too early, that she was the subject of sexual abuse as a teenager. So static and dynamic family factors, such as the mother's low level of education, accumulating family life events, lack of family cohesion, perceived lack of family economic resources, and female sex are predictive of gender dysphoria, plus mental health issues such as depression and anxiety that may be independent of family factors. Yep. Romantic and sexual relationships are another important area that we deal with in therapy. The majority of young gender dysphoric adolescents have had no sexual experience. They disdain genital sex as gross. They are indifferent to the loss of sexual function and fertility, and they're confused about the nature of trans relationships. From a clinical perspective, of all the young people I've seen in the past 6 to 8 years, I've identified 3 main groups. The first group are those young people with damaged attachment relationships, unresolved loss and trauma, adverse events of childhood, and psychological and psychiatric morbidity. In the second group are those with cognitive immaturity, learning difficulties, social skills deficits. They are on the autism spectrum disorder and they may have ADHD and are highly susceptible to influences. In the third group are children with no history of trauma, have intact families and secure attachments, who nonetheless are searching for peer homophily, other forms of connectedness, and who are struggling with the separation individuation process of adolescence. None of these groups are served by medical or surgical transition as the first line of treatment. It is imperative to keep the developmental path open into adulthood. Psychological trauma from the past forms part of the young person's psychic structure in the present. The expression of these traumas are both intrapsychically and socio-culturally embedded. Envy and rivalry are part of the human condition, and unconscious envy is a strong factor in transgender identification. Gender dysphoric adolescents need assistance to explore their defences and internal psychic conflicts and to manage their psychic pain before irreparably altering their bodies. Clinicians should not conclude with the fantasy that the embodied self can be altered or removed. Sexual development poses a threat to some young people as it signifies approaching adulthood, the demands of which they feel ill-equipped to manage. ROGD as a trauma or a response to the reality of puberty that one now has a sexed body has to be worked through and understood. Rigid adherence to peer norms temporarily assuages vulnerabilities because the young person has found others like him or her who are acting out in the same way. So transition could be related to a grievance against the parents and a struggle for autonomy and individuation. It could be related to an idea that one can create an ideal self, protective against feelings of inadequacy, anxiety, jealousy and disappointment, a triumph over feelings of vulnerability, and a repudiation of the sexed body and adulthood for which they feel unready. Youth trans culture has gone crazy and has even moved into the cat culture, is empowering trope, and there's a bit of a metaphysical, I'm not sure what my sex was before I became a spirit. There's adult collusion in trans youth culture, where children are not assigned a gender until they're old enough to decide for themselves, and to collude with the existence of a nonsense category called non-binary. Affirming clinicians reject the presence of mental health and issues despite their near ubiquitous presence in population studies of sex and gender diverse young people. They deny that sex and gender diverse young people need therapy before medicalised gender transition, or pay lip service to it to appease their critics. And they declare that any form of intervention other than gender-affirming care is conversion therapy.